Hi, this is Brooks Motley in Portland, Maine at the Maine Medical Center Emergency Medicine Residency. I want to share with you an opioid sparing technique for rib fractures called the Serratus plane block. This video is meant to be a brief introduction to the Serratus plane block, an ultrasound guided volume block in the chest wall to be used for pain control. We've started using this block in the ED at Maine Medical Center for rib fractures, but there are certainly other possible applications where anesthesia of this region is desired. It is still a relatively new technique, so published studies are lacking, but there are encouraging case reports in its application for rib fractures, breast surgery, and post-thoracotomy pain. My objectives are first to describe the anatomy we're targeting, the equipment you will need to perform the block, and then some videos of the procedure that I hope are helpful. This is a fairly straightforward block, but it can be hard to identify the proper plane until you develop a system for identifying structures in the chest wall. Stay tuned for a primer on this. This is not an exhaustive discussion. I would urge you to check out the references at the end of the presentation for more of the nitty-gritty. A particular shout out to Andrew Herring and the crew at Highland who have some great resources on their ultrasound website. To start, just a reminder of why we like targeted analgesia. Not only does it hopefully give your patient great pain control, but perhaps more importantly reduces the amount of systemic pain meds, namely opioids, going through the IV. In an often elderly population where taking deep breaths is paramount to avoiding complications, using regional anesthesia for rib fractures straight from the ED has great potential benefit. For obvious reasons, when introducing a large needle into the chest wall, this block mandates ultrasound guidance, both to identify the proper plane and to stay remote from the pleura. As with other volume blocks, i.e. the fascia iliaca, the idea here is to deposit a large volume of dilute anesthetic into a space containing multiple nerves, in this case the fascial plane overlying the serratus muscle. The lateral intercostal nerves are targeted here, and they're small, so you won't readily visualize them during the procedure. These nerves provide sensory innervation to the chest wall and skin. The effect does not reach the periosteum of the rib itself, rather treats the pain associated with muscle spasm and nerve irritation that are felt to contribute to much of the pain the patient experiences. So let's get oriented to the anatomy. The serratus anterior lies in the lateral chest wall by the big white arrow, and is deep to the latissimus dorsi posteriorly and deep to the pectoralis muscles anteriorly. Keep in mind the relationship to the lat, which becomes a helpful landmark during the procedure. The block involves depositing anesthetic in the potential space either superficial or deep to the serratus. While both planes appear to be effective, there is some evidence that the superficial plane leads to longer-lasting anesthesia. Given that this plane is also further from the pleura, it should make complications like pneumothorax less likely as well. Another useful landmark to orient yourself to is the thoracodorsal artery and its branches, which lie in the plane between the lat, which shown here has been reflected in the diagram, and the underlying serratus. This plane is the same as you will use for the block. So the nerves we want to target are the lateral cutaneous branches of the intercostal nerves shown in this netter drawing, perforating through and fanning out on top of the serratus muscle. Because the anesthetic is deposited in a fascial plane, it will diffuse throughout the space with the aid of the bellows motion of the chest, shown here in blue. As previously mentioned, the best anesthesia is obtained from T2 to T9. This block also seems to work best for lateral and anterior rib fractures more so than posterior. In this axial view, you can see the intercostal nerves coursing out from the spinal cord, then perforating through the intercostal and serratus muscles laterally and branching within our plane of interest. Again, our anesthetic is outlined in blue where it will spread in the plane. Now onto the equipment. A few basic things you will need for this block. In a 30 cc syringe, mix 20 cc's of 0.5% bupivacaine and 10 cc's of sterile saline. This is the same cocktail that we use for fascia iliaca blocks at Maine Med. Be mindful of the 2 mg per kilogram max dose of bupivacaine, especially if you're doing this block on a smaller patient. Also realize that especially in polytrauma, the patient may be receiving other blocks or applications of local anesthetic, and the max dose is cumulative from all of these applications. Attach a 20-gauge spinal needle to your syringe, remembering that first you must remove the stylet. You will also need chlorhexidine for the skin. And because of the large volume of anesthetic and theoretical risk of toxicity, intralipids should be available in the Pyxis in your department. The setup. As with any volume block, the patient should be on the monitor to watch for signs of local anesthetic systemic toxicity. The patient can either be supine for an anterior approach or lateral decubitus for a posterior approach. We'll stick with supine and an anterior approach for this video, given the discomfort many patients with rib fractures have in trying to lie on their side. Place your linear transducer in the mid-axillary line at about the level of the fifth rib, similar to where you would place a chest tube but a little more posterior. Whichever way you choose to orient the marker dot on the probe, do it the same way every time so that you get used to the images you see on the screen. All the images I'm using here have the marker dot posterior. Here's the image you will obtain. Notice in the video the rib at the bottom left and the pleura sliding underneath. As the probe is translated anteriorly on the patient, you'll see the lat tapering to a point from screen left to screen right. Below the lat is the serratus, and the plane in between is where you want to put your needle tip. Let's freeze the image and label some structures. Remember, the transducer is roughly over the fifth rib in the mid-axillary line with the marker dot posterior. This is the image you want to obtain in order to be confident you're in the right place. So we have the rib in the lower left, pleura just underneath that bright white line. Superior in the image, the lat is tapering to a point, and just below that is the serratus. The muscle between the serratus and the pleura is the intercostal. Marked by the star here is right where you want to put the needle tip and deposit your anesthetic. Sometimes the muscles and fascial planes may be less than crystal clear, at which point our friend the thoracodorsal artery can be helpful. This is usually going to be a little further posterior away from the tapered tip of the lat. Use some color to aid in identification. Once you see the artery, which is in the plane you're looking for, you can follow the plane to a place more remote from the vessel to inject. Finally, let's take a look at the procedure from start to finish. The skin has already been scrubbed with chlorhexidine, and I've raised a skin wheel with lidocaine to make the spinal needle a little more bearable for the patient. Just to refresh our landmarks one more time, you see the lat tapering to a point, the serratus underlying, and the intercostal below that just above the pleura. Always use an in-plane approach, doing your best to keep the entire needle in the image. You'll notice I lose it at times here. You can always inject a little anesthetic to see where your needle tip is. The most important point being to stay well away from the pleura. Watch your needle pop through the fascia at the base of the lat, then slowly inject. The fascial plane should spread easily. If it's hard to inject, or if it doesn't appear to be spreading along the plane, you may be in a muscle belly and have to adjust your needle a little more superficial or deep. Leave the entire contents of the syringe, and over the next 15 to 30 minutes it should diffuse through the space and hopefully make your patient a lot more comfortable. That's all I have in this brief introduction to the serratus plane block for rib fractures. Thanks for watching. You can check out the references on the following slide if you want to read more about it.